Okay, so I think almost everyone's connected, just a couple of audios still connecting, but I think we're on time and we've got a lot packed in for this morning. So without further ado, welcome back, everybody. My name is Nasreen Jassani. I am once again your co-chair today with Toby Brooks. It's my pleasure. I hope you are ready for an intense but a very productive 3 hours this morning. We had a really lovely session yesterday with input from experts in using implementation science in their teaching and their curricula. And today we all get to be the driver in the driver's seat and try to implement some of these new approaches in our teaching and pedagogy. And we'll do this through a hands-on practical session that's relevant to our own individual context. I won't give away too much too quick, but I'll let my co-chair Toby tell you more and share the agenda for the next few hours. Over to you, Toby.
Great, thanks, Nazreen. It's really a pleasure to be back here again. I got so excited yesterday, I didn't even introduce myself. I'm Toby Brooks. I'm at Texas Tech University Health Sciences Center. And really the point of today is fascinating. It's a critical one because if you're new with implementation science, now you have head knowledge, but we need to put it in practice. And so frequently in the literature, there's reference to the know-do gap. If we know something, but we're not yet empowered with the tools to do it, now we've got this dissonance kind of just boiling under the surface. And so Rachel's got a great exercise for us today to put these ideas into practice, because if I've learned anything over the years, it's that old habits die hard. Our belief systems are very resilient, and in light of new evidence that we believe even works better, if we don't have the tools and the practical strategies to implement them, then it just kind of sits there. So today will be very practical. That's the intent. For the introverts among us, it's probably going to be a little uncomfortable. We're going to spend some time in breakout sessions, and we're going to wrestle with this idea of implementation science. So once again, it's my pleasure to introduce our speaker for the day, Rachel Soicher. She's again with the School of Psychological Science at Oregon State University, and she will be laying out what our breakout groups are going to look like.
Great. Thank you so much, Toby and Nazreen, for that lovely introduction. I see a lot of familiar names on Zoom from yesterday, so I'm excited that you all were able to join us. I'm going to go ahead and share my screen with you to give you an overview or an introduction of what we're going to be working on today in our breakout rooms. If you remember where we left off yesterday, I had just introduced to you the evidence base for simulation-based education, which is a tool that's commonly used across disciplines in health profession education. I also reviewed this implementation research logic model, which looks really busy to begin with, but is actually fairly simple, or so I hope. And you might also remember that yesterday I spoke with you all about just dipping your toe into the pool of implementation science. So everything that I'm going to give you today is actual tools that are used in implementation science by implementation scientists, but I have gone through and modified them to hopefully make this exercise really just that shallow introduction to implementation science, to get you thinking about, could I use this approach? Do I want to use this approach, etc. Also, a review from yesterday, we talked a little bit about how mechanisms are not commonly investigated in implementation research, and that it takes a lot of underlying data to make guesses or hypotheses about what those mechanisms are. So I've put a little reminder in the worksheet for today that you can go ahead and just leave that section blank. So again, this is quite a long document, 7 pages, you can see. And the goal in your breakout groups is to sort of discuss, you might start your breakout group with just a discussion of what does simulation-based education look like in your local context. Get everybody sort of on the same page about, oh, okay, well, I use SBE this way and you use it that way, but we have some things in common, at the foundation. It's still simulation. And then what I'd like you to do, I'm going to go through these pages. The pages themselves also look very busy, but each page has a similar structure. So at the top is just a reminder about what the specific aspect of the logic model is that you are working on in the moment. So for example, on this first sheet, it's just talking about implementation outcomes. And hopefully you remember this diagram from the presentation yesterday. But if not, that's all right, because these variables are going to be defined for you in the upcoming pages. So following a brief explanation of what you're working on, there is a numbered list with directions. So you see here that number 1 says, for SBE, what are the clinical or patient outcomes you're interested in? And it seems that I missed there. That should actually read student outcomes. So for SBE, what are the student outcomes you're interested in? And the student outcomes are listed in the table at the bottom of the page. And these are the same outcomes that are listed above in the diagram. And your goal is to just pick 1 or 2 of these student outcomes that you think should be improved by the use of simulation-based education. So once you've chosen from this list of 6 items, 1 or 2 things, then you go back to the logic model and you put those in the student box over here in the outcomes. And although the logic model moves from left to right, the authors of the logic model recommend that you start with the outcomes because that's usually what you feel most comfortable with, what you know the most about. So our student outcomes would just be listed here. So if I just think that SBE is really great for critical thinking, I just put critical thinking in this student box. That's it. Then you'll see that number 2 states from it would help if I had done this correctly. I apologize. So next you'll be choosing from this list of implementation outcomes. These implementation outcomes from Proctor et al. 2011 are the same from the diagram and the ones that we spoke about yesterday. The ones above it in the top of the chart are from what's called the REAIM framework from Russell Glasgow and colleagues. And each of the variables has a definition next to it, so you don't have to wonder about what it means. And again, your job is to just pick 1 or 2 of these things that you think you'd want to measure in your own context about the implementation of simulation-based education. And then you go back to the logic model and you put it here in the implementation outcomes box. Questions so far? Okay, well, I'm sure they'll come up, but I'll be floating around in the breakout rooms. And so it goes on just like that also for the determinants of implementation. So yesterday you heard me talk a lot about the consolidated framework for implementation research, which is also known as the CFR. These are all of the determinants. Again, remember that's just a fancy synonym for facilitators and barriers. That might be relevant to implementation in your context. Again, I would encourage you to keep this simple. You might choose from only 3 of the 5 domains. You might choose just 1 of the domains. And then within those, you might choose 1 to 2 of the particular determinants that you think would be relevant or interesting for implementation in your context. And what I'm hoping will happen as you go through this list of determinants and as you think about what might be relevant to your context is that you'll be talking in your breakout groups about, well, for example, what is the level of peer pressure in your department for using SBE? And somebody might say like, oh yeah, a lot of our faculty are already using it. I feel like I need to get on board with it. That's something we should probably report if we were talking about implementation in our context. And somebody else might say, well, I'm the very first person thinking about using simulation. And so I don't have that, I'm lacking that pressure to adopt it. And then talk about what that might look like at each institution. What does it look like for implementation to have that pressure versus not? And so most of what you're doing here is having a conversation with the folks in your breakout group about what is going on right now with simulation-based education in your institutions or in your departments, or even in your own classroom. And how can we start to get information out about what that implementation looks like? So most of the pages of this document are just an explanation of the determinants. And so I recognize that this can feel very overwhelming, these charts. And take some time at the beginning of your breakout group to read through this and sort of become familiar with it. You have an hour and a half, so your group can kind of decide, okay, let's take 10 minutes to read through the worksheet and get familiar with it. Then let's each talk about what SBE looks like in our context. And then let's look at chatting about some of these determinants and how we might be interested in using them. So once you've selected those determinants, you just come back to the logic model and just write those determinants inside the domain that they belong to. So if you were interested, earlier I was talking to Andrea about sort of how do faculty feel about using evidence-based teaching practices. That would be a characteristic of an individual, and I would just put that right in here. So that is maybe people's propensity or people's willingness to adopt evidence-based teaching practices here in the logic model. So again, we're not trying to be comprehensive in this exercise. We're trying to be curious. We're curious about implementation. We're curious about what other folks in different areas of health profession education have going on. And I think this is a real opportunity for that interprofessional communication. And I hope that you will have a chance to capitalize on that. And then the last section is related to implementation strategies. And again, you see a definition here at the top of the page. These are some optional or additional resources because I know that this worksheet is also serving as a jumping off point for you later. This is not a set of websites I would encourage you to delve into during today's session. They're very extensive, so save that for later. Instead, rely on the examples or discrete strategies that are described in this table at the bottom of the page. Again, you'll just choose one or two of these things to add to your logic model. And so the list goes on to the second page about implementation strategies. And I would encourage you, when you're thinking about using implementation strategies, like you can't try them all at one time. And this makes sense from a research perspective, right? You can't modify 3 independent variables simultaneously and then make any conclusion whatsoever about which of them affected behavior. So the first time you teach with simulation, you might provide support for instructors and then see how they felt in terms of confidence of facilitating that interaction. Then the second term that you use it, you might provide that support because you found out it was beneficial. And then you will also engage students about it. You'll ask them how they perceived that to go. And I chose kind of 2 bad examples for that because you actually tend to measure these things together. They go sort of hand in hand. But certainly if we're talking about incentives or support for the educators, we want to be looking at which of these is essential to the implementation rather than looking at them simultaneously. So again, I'm hoping that that will stimulate conversation for everybody just about what implementation might look like, how we might all contribute to sort of a general body of knowledge about how to implement simulation-based education. And something that I think is really important to point out is even if SBE looks different for every person that's in the breakout room, the concepts of implementation science are the same, right? So if on this side of the room, I have 5 folks and they are looking at SBE versions A through E, all of them still have questions about what support do I need for my faculty? How willing are my faculty to implement simulation-based education? What are the students' perceptions? And I think the real benefit to that is if we can all get on board using the same measures for those sorts of variables, then what we end up with is a body of literature where we can actually compare the results of the study, as opposed to now having 5 studies that all talked about different things, and you can't really have a conversation about comparisons among those things because now the measurement of the variables is different. And that was a common critique that I saw in the literature, was that the published studies relied on too disparate of measures for the variables, that the reviewers were unable to really synthesize the results into a cohesive picture. And so we want to make sure that, you know, implementation research, you heard yesterday from, I believe, Natalie or Hannah, that there's a lot of terminology. Implementation science is called knowledge translation in Canada. It goes by a lot of different names. And then within implementation science, the terminology is just horrendous. And implementation scientists will tell you that right off the bat, that people use different terms for different things. So what I love about teaching people or bringing people to implementation science is giving you some terminology so that when you start out in the field with it, everybody's on the same page about what it looks like. Because that's what's going to be really beneficial as we move forward and we start building up these studies of what those implementation strategies look like. So anybody have questions about, I'll stop sharing my screen, about what we are going to do in the breakout groups?
Not a question about what we're doing, but just there's certain languages being used. And I'm assuming after having just heard you that part of the reason for using that language is so that the different studies can be comparable across different studies in a sense. Is that so using the language is actually fairly important in this exercise?
Are you able to give me an example of what you mean by some specific language?
So some of the language, even on the CIFR, you know, it's outer and inner setting, and then some of the language that's used to populate those boxes. There's some very specific terms. I think accessibility was one.
Yeah, I do think it's really important to stick to the terminology. Otherwise, as you move forward, you're all going to be speaking about the same thing in different languages. Yeah, so I think keeping with a common terminology is a good idea. And those variables, for example, the implementation outcomes, those are published. There are validated measures of those variables. So you can't just go around calling them something else. Yeah, if that makes sense. And I guess my overall advice to the group would be just like, don't overcomplicate it, and no one's policing your breakout room discussion. So if you get a little bit off track about the use of SBE, you know, you're still coming together across different areas and having those conversations, which I think is beneficial. Any other questions? Points of clarification. So I will be bouncing around, meaning that I can hop into an online breakout room if there are questions. Each of the rooms will have a facilitator, if not 2 facilitators. Oh yeah, 1 facilitator and 1 scribe. And if that person is not comfortable answering your questions, they'll just kind of tag me into the room and I'd be happy to help. Same for in person here. I'm happy to wander around and check in with folks. That's typically how I teach, so I'm pretty comfortable with that. And now I think the breakout rooms are set to start at 9. Did we want to take a break for 10 minutes, or did we want to hop right into the breakout rooms?
Let's take a 5-minute break.
Okay, we're going to take a 5-minute break, we decided. So we'll be back here at 8:56.
All right. So welcome back, everybody. I hope it was, I know in our group, the hour and a half went by super fast. We didn't even have time to break until the last 2 or 3 minutes when Hannah alerted us that we've only got a few moments. We're like, oh, we better break, bathroom break, leg stretch, coffee, tea. So I don't know if it was the case for all of you, but we had a very engaged team. So I'm really looking forward to hearing everyone's reflections and seeing how the groups did. So I'm wondering, it would be really great if, for those of you that are comfortable, to just unmute your mics, so put your hands up so we can call on you, or write in the chat. But I think the first question I'd like to ask is always a positive one, is what were some of your aha moments? What did you realize as you conversed about doing implementation science and health professions education, as you tried to complete the template, as you were working your own example? Were there any light bulb moments or aha moments for that particular hour and a half that you're working together? Any brave souls? I don't see any hands up yet. Is anyone going to unmute?
Anna has her hand up.
Shauna, go for it. And then I think I saw Gail also wanting to speak. So Shauna, then Gail. Go ahead.
Sure. So I think, in our group, one of the things that we all commented on was that the process of doing this together actually spurred some individual thinking for our projects in terms of outcomes. And so we had sort of a larger framing around disaster preparedness as our simulation-based education. And so then we started talking about, well, are we thinking about this in the context of continuing education or new learners? And we went through the entire logic of model process. And so as we were sort of talking about it, then different people were coming from a variety of different perspectives. And so having the ability to go through the steps, I think, was really helpful for all of us. And then also just being able to have the crosstalk across the different groups and the different individuals was one of the major, I think the process of this was fantastic for our group.
Super. Thanks, Shauna, for sharing that. So if I understand correctly, you all worked on one example. Is that right?
So we spoke through, we talked through one example. So we started off by sort of introducing ourselves, talking about our content areas. And then through that, there were several people who were working sort of in the space of disaster preparedness. And so we decided to focus on that as a group.
Cool. Great. Thanks for sharing that. Gail.
Yeah, I guess I didn't have my hand raised, but that's okay. I'll make a couple of comments and Toby can chime in. I think that the discussion was very generative. You can start with the end in mind, the outcomes, like Rachel suggested, which is easier. The messier part is the implementation. You can identify what are the barriers and facilitators, but I think we had a lot of discussion about implementation, return on investment, and I would say the importance of the kind of a philosophical grounding in shared values and beliefs about, why are we doing this, how does it fit, and the importance of doing it. That's critical in any curricular discussion.
Yeah. No, super. Thank you. Any other aha moments, light bulb moments, realizations? I'm gonna then pick on someone in my group, and I'm gonna pick on Darren because he had a great aha moment that he shared within our group in terms of, as he was filling out the template, just this realization on where we've come from in terms of health professions education and where we're at, and this refocus on not the acquisition of knowledge, but the application of knowledge, and how implementation science helps kind of crystallize that kind of thinking. Darren, could I ask you to perhaps articulate a bit more about that particular point that you'd raised in our group?
Yeah, thank you. It was, as I was running through most of my thoughts on the project that I was keeping in mind, just to kind of frame it, where I was the use of simulation, the conversion of simulation into more of a virtual reality environment for those very difficult to reach areas. Our institution has a lot of rural areas, so we're implementing some virtual reality for an experiential simulation. And as I started thinking about this, what I realized is most of where we're going is shifting our thoughts on education from achieving nuggets of information to applying or an application-based, aptitude-based use of the information. And that is, in fact, where we're heading with all of higher education now because of the ubiquitous access to information on smartphones and computers and through the internet. So how can we use these tools? I was asking myself to challenge both the facilitators, our teachers, and our students in the application, aptitude-based use of information as opposed to achieving information and really not having a way to apply it. So it was really the origin of the exercise I was going through.
Thanks, Darren. Does that resonate with others? Kim?
I think that's a great point. I'm going to sort of branch off slightly differently and build off a discussion that actually happened in the forum meeting yesterday about involving students in the entire process. And just a shout out to Jeremy, who provided our student perspective, who was in our group. And then also to Hannah Wilson yesterday, who talked about how she first starts by asking questions of the stakeholders about things that really are working, maybe things that really help, things that they really want, and how that helps create some of this background as a whole. I just found the student perspective in the process and looking at implementation outcomes for all your stakeholders, I think is super important. And that just crystallized for me as we were starting to talk through this.
Such an important point. We always talk about stakeholder engagement and making sure we have stakeholder perspectives. And I realize that the biggest stakeholder actually is our students. So that's a great point. Did that then affect the way that you populated your strategies and your implementation outcomes then? Kim, you're nodding? Yeah, okay. Great, thank you. Anyone else with an aha moment that can be useful to all of us? Okay.
I think one other item that came up in our group was under the process of the
determinants?
Determinants, thanks. Yeah, under the process, it seemed as though that was necessary regardless of whatever implementation science or logic model you're going to be working with, that you always had to include all the elements of the process. Now, I don't know if that's true or not, but that was kind of something that we came to in our group, that these are necessary to report on no matter what. Reflection, evaluation, there were some other points in there. We're thinking, oh, I don't know how you couldn't report on this.
You'd be surprised.
Yeah.
But no, I agree with you. I think the process of implementation needs to be detailed so that it's useful to somebody else wishing to adopt the same process.
Yeah, absolutely. All right. If there aren't any other great realizations that you feel like sharing publicly, please put them in the chat and share those with us regardless, because I think this is a great opportunity for us to kind of bounce learnings off of each other. But I guess the next question then is, for some of you, as you mentioned yesterday in the poll, you already use implementation science in your teaching. But for many people, you don't or didn't realize that you do and realized afterwards. What were some of the challenges of trying to think about this in a more systematic way, perhaps, than you've done in the past, and documenting them through a very nice template that Rachel provided for us? Were there any challenges or difficulties as you were thinking through the different sections and populating them? Anyone brave enough? I might randomly pick on people. Ah, there we go. At least we've got a hand up, Rachel.
Yeah, so I'll say something that I observed in our group was that we would talk about a potential determinant, and then folks would say, but isn't that also an implementation strategy? And isn't that also an outcome? Which is, I think, when you're just getting started with implementation science, really easy to get lost in, well, where in this diagram should this go? And so one point that I made to our group that might be helpful for others is that where it belongs is going to depend entirely on your perspective. And there's no one right way to categorize it. So the key is to be transparent in your reporting of that information. So with simulation-based education, we talked about it not in a specific manner the way Shauna's group did, but just more generally SBE as we each use it. You know, it was, well, when we involve students in the design of simulation-based education, is that an intervention characteristic or is that part of the implementation process? And I said, you know, if your perspective is that there's 3 stages to simulation-based education and you're just thinking about the first one, then perhaps it's part of the intervention characteristics, but just explaining that it'll depend on your perspective. And so you don't have to necessarily be able to fit it nicely into one of the boxes.
Yeah. And there is that fluidity, right? We also talked about one of Proctor's implementation outcomes that wasn't on the list, which is adaptability, because that's also a really important implementation outcome. But sometimes that can be in some ways contrary to fidelity, because if you're looking for fidelity, then then if it hasn't gone exactly right, it's because you've adapted it. And then you want to document why you've adapted it and why that made sense. But that means you might score yourself lower, not score, but kind of evaluate yourself lower on fidelity. But that's okay if that's what your intervention required. So that's interesting kind of reflection that we were having. Pamela, I see that you unmuted. If that's a mistake, I'm sorry, but I'm going to assume that that's because you wanted to say something. Did you? Pamela?
Oh, me? No, I unmuted unnecessarily, but we had a good discussion. I think I will just make a few comments on the simulation-based education. It's really important to have a plan. I like the logic model. All those were important considerations before that is done. And having an integrated model in the curriculum that with specificity on why you're doing what you're doing because of all the cost, the return on investment, and what's the value. And I think people probably know I support simulations greatly, but it has to be well thought out. And a question that came up in our group, and there's not a lot of evidence on it, but when do you use simulations and for what? And what type? When do you use high fidelity mannequins versus standardized patients versus virtual simulations, screen-based simulations? Those are all big questions and really important for this group with our teaching, learning, and scholarship in this endeavor to get the evidence so we can support each other. Thank you.
Yeah, super. I'm glad you were unmuted because I think those are really nice reflections to share. And I see that we've got also in the chat, we've got a comment from Eric in terms of the challenge of complexity that's embedded in all we do. And Eric, I don't know if you want to kind of expand on that a little more so we understand the perspective you're coming from.
Yeah, only that I think a lot of what we do in education would be categorized as a complex intervention, which just simply means that it's multi-component or multifactorial. We don't tend to do just one thing. There are multiple aspects to the intervention. And so that complexity, when you think about it from an implementation perspective, I think comes into play on a kind of regular basis.
Yeah, thank you for that. And then I see that there's another comment in the chat box and lots of people agreeing with Deb on her aha moment. So Deb, if you want to unmute and share more, I will read your comment though, regardless. She says it can be challenging to take the experiences of the students into account when the students are also faculty or teachers or experienced clinicians who bring their own styles to their participation in the intervention. And it seems like that resonated with many people. Do you have an example in mind, Deb, that kind of spurred that thought?
Sure. I've been, I think in our subgroup we spoke about, I've been in the informatics domain working in electronic health record teaching, and I'm thinking towards the complexity of meeting all of the different types of these experienced learners where they want to be, and trying to find interventions that are, you know, flexible enough, so to speak, that do that. And that came out a lot when I was going through the worksheet today.
Thank you. Thanks for sharing that. And it looks like it kind of touched touched many people. Kathleen, I see your hand up.
Yeah, I just wanted to share that, you know, this is a great tool for, you know, supporting sort of that preparation of how to deliver a simulation-based experience for students. But I guess, you know, one of the challenges that I posed to our group was how to effectively measure the outcomes and the effectiveness for students. We can talk about how it meets our curricular objectives and maybe how it addresses many skills that we want to see in our student outcomes, but how to effectively measure that, because sometimes when you do these sort of pre-post, if you did like sort of, we talked about a confidence, you know, sometimes students will overrate their confidence until they get into the weeds and realize, oh, I don't know as much as I thought I did. And so then it doesn't reflect positively on you at the end. And so in some of those outcomes and benefits may not be able to be measured immediately at the end of that simulation or at the end of that experience, and maybe later on. And how do you capture that? So
that's a really great point. And I see lots of nodding heads. Rachel has a response. Go ahead.
Yeah, thank you so much for that point, Kathleen. And I think that goes back to thinking about what is the evidence base for the practice that we're implementing. And I think for many systemic reasons, we jump right into adopting a practice because it seems like it will be good. And we did have a comment in our group about sometimes people who are innovators, who are at the forefront of leading the charge into these practices, are actually having a lot of good foresight. And it turns out later that a lot of evidence does support their decision or their choice. But I think when I was looking through the evidence-based practices, the simulation-based experiences, and then also the other ones I presented yesterday, like any other pedagogical practice, there's very little longitudinal follow-up with students to see what is the effectiveness of this 6 months from now, a year from now. And I don't think that's necessarily an implementation question as much as it is an effectiveness one. And unfortunately, I think a lot of our research is just limited by resources mostly, and ability to follow up with those students to see if it has that long-term effectiveness we would hope for.
Thanks, Rachel. Did anyone else want to comment on that particular point? Shauna.
Yeah, I just wanted to also say that our group has struggled with the same question that Rachel raised earlier. But in addition, we had a couple of different things that we sort of noted. So one was we thought it was really helpful to start with the outcomes, but then one of the questions that came up was sort of, is there a hierarchy of outcomes? And in terms of the way that we think about this in health professional education, really we're focused on the students and the learners and not necessarily those clinical patient outcomes. And so just something to be sort of thinking about as we sort of work through it. And then the other part was something that Tony brought up in terms of thinking about this as an iterative process where you have to go back and forth between sort of here are the outcomes that we started with, but as we're refining the research question and thinking about this process, then how do we actually sort of go back and forth between the different pieces? So those were some of the things that we also talked about in our discussion.
Yeah, and I will just note here in the room, it's funny that you say that because our folks started first with clinical outcomes. Well, this is what we know we want to have happen in the clinic, and how do we work backwards from that? So just a funny sort of perspective shift, I guess.
Hmm. And I think that's natural for all of us to, it's a lot, we started with student outcomes because we followed your guide, Rachel, and we started there. But that was in some ways quite easy because I think everyone that is teaching has, over time learned how to write really good objectives for their class, which link very well to the outcomes, what you want students to achieve. But then when it came to implementation outcomes, that was a very different way of thinking. It wasn't as intuitive, as natural, but it wasn't as hard, I think, as we might have imagined that it would be. And that implementation science not completely out of the realm of what most people are already doing, if I'm fair in assessing at least the reactions in our group that way. So I remember yesterday there was a question on, is this only relevant for the classroom, for didactic teaching, or is this relevant also in clinical experiences? And I'm wondering, after going through this process, I remember Rachel saying yesterday that implementation science, without being flippant, you don't want to be flippant, is relevant everywhere. And I'm wondering, after having gone through this process with either a joint example like in Shauna's group or individual examples like in our group, how you're all feeling about whether this is relevant in a variety of the settings in which you are all embedded, whether clinical or classroom, and wondering if you have any reflections on that.
I actually do. This is Mary. So actually, I teach improvement science to doctoral students to be a nurse practitioner. So as I evaluate the implementation science model and the research, there's a lot of overlap. So my question is currently I teach implementation or improvement science modality to address a clinical or healthcare concern. So I'm wondering now, should I be teaching more implementation science? And or is implementation science actually an evolution of improvement science? So I just kind of throw that out there to stimulate thinking and thoughts on that, because I do see a lot of benefit in this model as well.
Thanks, Mary. I don't know, Rachel, if you had an immediate response to that, or whether that's something for us to kind of put our thinking caps on about.
Yeah, I'm so sorry. I was wondering if perhaps Gail or Hannah wanted to chime in on that, if either of you know.
What I know is I know the Carnegie Foundation for the Advancement of Teaching has done quite a bit with improvement science, that concept, but that's about all. And I think there probably is a connection. I think it's a good point.
I haven't delved much into improvement science, so I don't know that I can speak to it. I definitely do think there is a connection, but I don't know if one is better than the other for a particular context.
Yeah, Eric's added some information to the chat about the origins of each of them being slightly different, which aligns well with my perception of they're very similar, but have different origins. And so like many other things that overlap, they stay separate because they're used by separate sets of people, not necessarily because they're truly meaningfully different things.
Yeah, I would agree with that. I think, if you look at the CFIR, it's informed by all kinds of research. You highlighted Everett Rogers' work, which is one body of work. There's also social sciences in there from people like Ray Paulson and Nick Tilley. So it's really an amalgam. And so health services research uses a lot of implementation science thinking and has it, but it's also somewhat arguably missing the educational elements, when thinking about a health services intervention. The Carnegie report has been Tony Bright, who's there and led that, and was heavily informed by the quality improvement work that actually informed their thinking when they wrote that up. But you're right, I agree, Rachel, there's all kinds of overlap between these things, and there's intersections, and one's kind of informing the other.
I think there's another.
Great. Did anyone else have a comment or a thought before
We have a comment. We have a comment in the room. Kim Lemus.
Go ahead.
I was just going to comment in terms of the application of implementation science in the context we've been talking about it today to clinical rotations and clinical educational settings. I think we have often dismayed as educators that the clinical environment is sort of the Wild West and we don't have much control. But there are some innovations where we try to create a framework for certain interactions, and I would think that implementation science would be really critical to doing that well. So for instance, if a student's starting a new rotation, you want to set up a standard where they would meet with one of their supervisors to talk about their educational objectives for that rotation and what kind of feedback they hope to receive. There would be a lot of implementation science around making that happen in all the different settings and thinking that through. And so any attempts that we have of putting some structure around those clinical environments, this becomes really, really important given the complexity of those settings.
And I'm wondering, are you talking about the linkage maybe between education and practice? That implementation science could, I don't want to call it a bridge, but maybe a way of bringing the two together?
When we think about education in the clinical setting, I think that it's easier to think about implementing something new in a classroom setting. It's more control. And I think if you're going to do something in the varied experiences of students across multiple different clinical settings, implementation science becomes all the more important to think through to ensure that first that it actually happens, and then second to try to evaluate whether what you tried was effective to learning.
Thank you for those comments. I didn't catch all of it. It was a bit faint for me at least, but clearly there was it was interesting, and that Patricia was able to kind of clarify a little bit of that. And then we have one more comment here from Dr. Palmieri. And I don't know if you want to say more to that comment before we move to the next part of our workshop today.
I just think that I serve as the deputy editor for a journal that looks at quality improvement, and we have huge debates about implementation science versus improvement science versus whether it's called research or science, and translation research versus science. And I would just say that we have a real problem with defining the words, as we spoke about earlier, that we use as normal nomenclature as scientists. And I can't imagine like professions such as chemistry or biology having these serious problems that we have. Can you imagine in biology if we had like 10 different names for every different compound? Or I mean, in chemistry, this just is ridiculous. So I think it's incumbent upon us to recognize other disciplines have gotten their act together, their proverbial poop together. And I think that we need to get our act together and start defining these terms clearly and concisely so that we can start working in the same sandboxes rather than creating our new sandboxes, which is, I think, the result of many assistant professors trying to claim their stake in the tenure process. I mean, we just create new terms and new ways of doing things instead of just applying what we already know. Thank you.
Thanks. And I don't think it's only the health professions discipline. I do think that occurs across disciplines, because that is the incentive of academia, unfortunately. And we see that also in the social sciences. So there's also lots of confusion there. But I do think that the point is that we should be able to put a stake in the ground. We should be sharing, publishing, writing, and adding to the knowledge base out there. And like discussed yesterday, sometimes they're not sure where that needs to be. And Zori had a great suggestion about this is where we need to be forging a path and through an interdisciplinary professional kind of lens. So I think we've got some tasks ahead of us. And speaking of ahead of us, I think now it'd be great for us to kind of be future thinking. What are our next steps? What does this mean? What have the 2 days meant for all of you, for us, and for health professions education? And in order to facilitate that conversation, I'm going to hand over to Toby to take us through that. So over to you, Toby.
All right, thank you, Nazreen. So we're in the home stretch, and if you're like me, this entire pandemic experience has left you with no shortage of Zoom calls and virtual presentations and virtual workshops and all of those things. So first of all, I'm really jealous of the group I'm looking at right now who are sitting in a room together with human beings. But the takeaway is really what we're after at this point. Like, what was the point? So we've got a poll that we're going to post here momentarily. Hannah's going to pull that up for us. And we just want to know, how comfortable are you with applying implementation science in HPE after this workshop? You get one vote. So we'll give you just a moment. And in much the same way the breakout session was an unknown quantity, this discussion will be an unknown quantity because your answers will dictate which direction we take next. So, and whenever those have tabulated. All right, well, hey, mission accomplished. Awesome. This is good. At least there were no one said less comfortable, so that's good. So that begs the question, what aspect of health professions education might you use implementation science to study? One of the common themes in our group was that, this is highly situational specific, it's institution specific. So in order for us to kind of throw 7 or 8 people in a room together and talk about this and come up with one consensus is a real challenge. And we recognize kind of the arbitrariness of the assignment. But to be honest with you, that uncomfortability, that discomfort is the word I'm looking for there. That discomfort was part of the process. We wanted you to struggle through how this might work. And in the process, you're thinking through, well, in my setting, I could do this. So what aspect, we talked about sim-based education, what aspect of HPE might you want to use implementation science to study in your individual situation right now?
Feel free to use the chat as well if you're shy about speaking up on the Zoom.
Yeah, Patrick makes a great point. Less comfortable would be applicable if we consider the uncertainties. Yeah, this is a slippery mountain to scale, and sometimes it can be difficult to find the handholds that we're going to grab and pull ourselves up. And so I like the process, and I think the process can certainly be applied in all of our respective situations. Kim, you said situated learning approaches. Care to expand upon that?
Sure. And I mean, I think it's messy too, right? One of the advantages about simulations is that you have a fair amount of structure around it. And I think Pat DeLeon talked about, the sort of reality of real world experiences and how that can be a bit more messy. But we do have some opportunities to work with patients in the classroom where each patient is slightly different. So the student groups do get different experiences. And it's almost like we could do a mini study of how that works. But there are so many different variables. There's no ways a formal randomized control study would actually work under those circumstances too. So it'll be more messy, but I think, based on the fact that the real world activities are meaningful for students, that might be a challenge to take on.
Yeah, and I would like to just pipe in relative to that, Kim, and Natalie Douglas brought this up yesterday during our roundtable discussion. Something that implementation science has really brought to the surface for me is that RCTs really aren't the gold standard of anything. I mean, I say that sort of tongue in cheek, but, you don't have to randomly assign your students to experience one type of simulation versus another to know how that experience was for them, or to assess what their ability to, communicate empathetically with somebody was. We don't need to rely on only quantitative methods to be making these decisions. And I will say, from where I was 5 years ago, when I sort of started this implementation journey, I have so much more of an appreciation for other ways of knowing now that have been really beneficial to me. So hopefully that could be a direction other folks move as well.
It's a great point. I'm trying to monitor here, see if anyone has a hand up.
I also had a point I wanted to share. I learned a lot about implementation science from Deborah Bingham. She's out of University of Maryland. But one of the things that came up in our small breakout group was that simulation in particular can tap into various levels of trauma with the student and the faculty based on their past experiences. So I think that that's something that we shared in the group in terms of the structure and process of how we implement and the planning. We need to keep that in mind, how we're going to tailor to people as they're going through these simulations and they tap into their own past experiences of loss. For instance, with me, in palliative care, we do a lot of simulation and we do deal with individuals and faculty that experience their own loss and grief. And so simulation can tap into those emotions and those past experiences. And how do we cater to that and make sure we're doing a good job?
Thank you so much for bringing that up.
Yeah, that's a great point. Monitoring the chat here, Mary mentioned Interprofessional Leadership Master Program. Mary, care to expand upon that?
So actually, we'll be rolling out a new master's program at the university. And I was actually, thinking about studying the impact of the program and what models and framework to use to appropriately track this over the first year. This looks very interesting. I think that I can probably slot in the program outcomes for the student outcome piece and kind of a number of the factors, the determinants. We pretty much kind of went through that, but it's a great kind of checklist or guide to actually kind of just test to see if it was successful or not, or what was the impact. So it's, I need to do more reading on IS, but we'll see how it goes.
Yeah, no, I think we are in an age of accountability, and any institution or any organization that's going to invest their resources into a program of any sort, we've got to be able to, we mentioned this in our group, that ROI. Gone are the days where we just have this altruistic mission where we're going to build leaders or we're going to build healthcare professionals. We have to demonstrate that, and this is where IS comes in. Dorothy, you had your hand up.
So I kind of built, I think, on some of the assessment and program evaluation comments people have put in the chat. I'd already had an idea and feel a little more confident after the workshop. We're charged in my association with building some resource guides related to like diversity and recruitment. And I'm wondering about using implementation science when we talk to our schools about this worked here. Why don't you borrow this practice? Because there are some good ones, but they never seem to translate. So I'm thinking about it honestly more at the program level than maybe the educational level, but I found this really helpful to think about that.
Yeah, it certainly can. I think it helps us leverage efficiencies that are in the system that we didn't know were there. And at our institution, we have 6 schools. Other institutions might call them colleges, whatever, but they all kind of operate on a boutique basis. And we do what's best for our respective school. And every other school is doing the same thing, but we we lose the ability, we haven't taken the opportunity to leverage what everybody else is doing well. And this just creates that dialogue where we know that we're all chasing after similar outcomes. Patrick, I love your quote here. Care to expand upon that?
Yeah, I think working internationally for the last 15 years has been very challenging because most universities in Latin America, many of them are for-profit entities, although some of them have like some sort of not-for-profit focus. And I'm finding that simulation labs, with exceptions, obviously, and I know of the exceptions, are largely implemented for marketing reasons and, you know, to show that their institutions have technology. In the educational reform in Peru, for example, we've closed 44 universities. And the universities that are open, that are still open, many of them implemented simulation laboratories for the sole purpose of being able to show the accreditors from the government that, look, we're doing things with technology, right? And quite frankly, our simulation laboratory is used many times to house biological and chemical experiments because people are not using it for simulation. They're very expensive. So the other thing I would say too is simulation is very focused on medicine more than nursing in many cases. There are exceptions to that, of course, because medicine, there's a machista, very different type of culture in this region than we have in the United States, where there's clear discrimination and problems with gender bias in education. And so what I would say too is one of the issues big issues we have is the translation with the language, English to Spanish. And so we're not often taking, I mean, very important information from other contexts and cultures and countries and bringing it to Latin America because people can't read. And it's sad, but many people in my country that are academics can't read both languages. So we're not able to bring the knowledge here, even though it's been well established with, with tweaks for culture and context. So I think in the United States, I think people need, and especially for assistant professors, people need to consider this because there is a huge amount of work to be done in basic implementation science in the South, and probably as well in Africa, because I have a lot of colleagues there as well. So that's the only thing I would add to the conversation.
Oh, that's great. I think it helps illustrate, it's an issue we've discovered here. We're in the midst of completing a needs analysis, a faculty development center. Most general academic campuses, they've got a faculty development center. We have not historically had one. Other health professions, institutions, health sciences centers, in a lot of ways, we're 20 to 30 years behind what the general academic campuses have done for faculty development. But on the other hand, how do we benchmark? Well, no one else is doing it yet either. So implementation science from the jump is going to help those programs establish what metrics are we going to be measured on? How are we going to assess the effectiveness of this program? And something we mentioned in our group, if it matters, we measure it. And implementation science allows us to figure out how we're going to measure it. It's really up to us to decide what we're going to measure. So in your case, Patrick, it may be the presence of a sim center it checks a box, but it certainly isn't moving the needle in terms of teaching effectiveness on your campus. So I think another question to consider here is where are we getting this evidence? Something I've come up against is a lot of the research that I've found and have based a lot of future work on comes from secondary and even primary education, where it's teacher scholarship of teaching and learning studies built around fifth graders, and fifth graders aren't the same as med students. And so we have a dearth of med ed research relative to the other body. So I think one aspect here that we could use it to study is what we quote unquote know about learning theory and such is probably not rooted in a similar type of environment to what we're talking about now, not to mention questions of diversity, equity, inclusion. I mean, there's so many aspects of what we recognize as the existing literature base that is so woefully ineffective, inadequate to describe the institution that I work at. I don't know if you would agree with that, or if you have similar thoughts at your institutions.
Toby, it's Chris Aronson. I'm here in the room. I would agree with that. I think that we've tended in the health professions to lose a lot of workplace learning literature from 20 and 30 years ago that's very relevant. I've been kind of living in that space recently, and I think there's value to us resurrecting that and then using these kind of tools to apply it and add in the new things that we know about diversity and equity and the other issues that you brought up that may not have been part of the conversation that long ago.
So you're telling me if I'm an assistant professor, I can dig up some old workplace literature and add my name to it and make a name for myself?
That's another huge issue, isn't it? I mean, it's a big problem. It's a big problem.
Yeah, there's just so much to be said for common language, and just, I don't remember who mentioned it earlier, but what's the difference between science and research? We talked about that. What is the implication of implementation versus some of the other definitions? Well, the problem is the more disparate we become, the less momentum that we can build upon. And this really is a movement in health professions education. And we're not blazing new paths here. Our peers and our colleagues in other disciplines have done this a decade or two ago. And we really can just follow their model and make it unique for ourselves. Kim, I don't remember who was next, but I'll call him Kim.
Gail, and then Pam, and then myself, so.
Okay.
Yeah, I'll be quick here. I mentioned the concept, the commuter concept. Years ago, Lee Schulman gave just a really terrific short talk at AERA, the American Education Research Association, to Division I, which I think does a nice job of bringing people doing education research across disciplines and to talk to each other, to use the learning sciences and make, just like Rachel has done, bring folks like Rachel to the table. And there's a lot of good stuff that goes on. Medical education has a very deep bench, much deeper bench of PhDs in education research than the rest of us. So we can learn from each other. And this group, I think, does a nice job, but there's so much more we could be doing. We need to commute.
Oh, that's a great point. Pamela, I believe you were next, Kim said.
Thank you. So great dialogue. I agree that the simulation research is still embryonic, but I got to tell you, it's exploded over the past decade, 10 years. I mean, even when I first started in the work in the early 2000s, there was not much. A simulation study would just be, what does it mean? You didn't even know. But we have had to borrow from theories, from the learning theories that you talked about, Toby, from other disciplines and sciences, which I think is fine. That's that translation piece and using into our world. But all of us on here, I encourage to add to the body of evidence in this educational piece of simulation-based education, and it does transcend across all the health professions. In the Society of Simulation in Healthcare, SSH, there's a dictionary for terminology, for the taxonomy, some of the common terms, even in simulation. We talked about research, science, translation, improvement science, all that. That does overlap and intersects. But when conducting simulation research, if we could start using some of the same taxonomy, and in SSH, they have a dictionary for this. And that's why INAXO has those standards that were talked about yesterday, standards of best practices, because more that we can unite using those standard terms and terminology, it helps us with our research versus we're all over the place. So thanks for the great dialogue.
Thank you for sharing that. Definitely, I will check into that. I wasn't aware. Kim, you were next.
Thank you so much. And, just a great discussion overall. I think one of the sort of questions related to where to go next, and this is more of a question if anybody has any comments on it, but if we were starting to look at publishing and using this type of framework within our own disciplines, within the interprofessional literature where the implementation science concepts are not quite as well known or rigorous, how do you think that that sort of next step about distributing in the literature, going to an implementation science journal on the one hand, where a lot of the theory, the definitions are well known, but in the medical literature, And our literature, as you know, from an interprofessional standpoint, or individual professions, it might not be. So I don't know if anybody has any thoughts on that. Rachel's done a great job of putting together the application of implementation science, and her article is a great framework to build off. But any thoughts from a reviewer's perspective?
Kim, I think that's a great point, and I won't be exclusive in picking on assistant professors. Let's start a new journal for the associate and fulls out there. We need an HPE implementation science journal specifically. No, I'm kidding. I think what you're doing today is evident that these are leaders, and we need to link arms and help one another on this journey. And in my area of practice, this isn't even a thing. And so there's an awareness piece that I need to bring to my discipline, even within the rehab sciences. I think Gail would probably also agree. PT, OT, this is embryonic is a great word that you use, Pamela. I think it has an opportunity to dramatically change the face of what health professions education will look like a decade or two from now, but we have to do the lifting now. Anyone else? Did you identify any opportunities using implementation science outside of simulation? We've already kind of touched on that. We real briefly alluded to telemedicine. I mean, there's certainly some tech out there on the periphery that would be worth investigating. Darren, you have your hand up.
Yeah, thanks, Toby. You said something that sparked a thought that I thought I might bring up as we're summarizing this. But in our early discussions about developing this workshop, there was really a very real focus on what happened in the pandemic and what could we have done to navigate through it easier while maintaining our education and being able to implement change for patient care. And the one thing that we all landed on was implementation science, and had the disciplines in the healthcare fields understood this well enough, we actually believe we would have navigated the pandemic smoother, easier, and perhaps faster to some of the outcomes that we are looking for, that we ended up with. And so I think as we start to finalize this workshop and the discussions wrapped around health professions education, we're all in this room because we want to learn something new about how to do things better. And what I think is important about this is if we're educating our new generation of healers and the new generation of knowledge developers, and we're bringing a new tool for implementing those pieces of information into the actual care of patients, we might be able to navigate things in the future a little bit easier, smoother, and faster. And so we've kind of come full circle now. We're talking about some disciplines that aren't even talking about this, and we're talking about other disciplines that use this on a regular basis. So how can we be the implementing force to get more people out there understanding this and being able to use it and not criticize each other because it's not a randomized placebo-controlled double-blinded study. So just thought I'd bring that up.
Darren, I think that raises really great questions about how do we disseminate the information we're generating. Most of my own work is not eligible for publication in implementation science journals because they tend to be biology-based or medicine-based or mental health care based is pretty frequently the case. And also educational psychology journals will not publish it because it's like not quantitative enough. And so where are we left then in terms of a database where this information can be provided quickly and easily by folks and is readily available to folks that want to use that information? And then how can we incentivize people to synthesize the information that's there so that every individual person isn't responsible for synthesizing an entire database worth of information? And I don't have answers to any of those questions, but I think they definitely come naturally from what you were talking about.
Yeah, and I think this is great, future workshop material as well. But one of the things that I think is very interesting about the tools that you've brought to the table and that we all began using today, and these don't differ very much. Their applications are used slightly differently, but they don't differ very much from what the business world is using to implement process and process improvement. Rapid cycle evaluation of various things. I mean, there are a lot of industries out there that are using it, using strategies like this in order to implement the changes that their teams are developing. And I think that's where we have to be creative. We have to see that these other industries, this is an IPE exercise for us. We have to see how the other industries are being successful with this, and then bring it into the healthcare fields that we're using. And again, while it was a little bit of tongue in cheek before, it's not randomized placebo controlled. The reality is we are so mired in the culture of what we did 100 years ago that many of us just can't get out of our own way. And that's the challenge. We have to be able to work within an environment where these tools are seen as just that, tools to help us make change. I know for me, no matter what we do at Texas Tech University Health Sciences Center, it's about the patient care that our graduates are going to give. So if we're not driving something that can be applied to or eventually introduced into the care of an individual to make their health better or create wellness, it's not something we want to invest in. So do we wait, as Toby educated me on, for a behavior to change, which takes 17 years in academia, 17 years to implement a change. And that's an actual number. That's not made up. It's 17 years for us to put a change in what we normally process. So while I think I'll be here in 17 years, I'm not sure that's actually realistic. And so how do we make those changes so that we can begin jump starting those healthcare outcomes that we've been imagining for the last couple of decades?
Excellent. So we're right up against time, and so I want to be respectful of that. First of all, I want you to recognize when you sat in your breakout rooms, it wasn't super comfortable because it wasn't super scripted. And so first of all, I want to thank Patricia. She is the organizer of organizers, and for her to let the reins out a little bit and let us have a little room just to kind of stretch out and have some honest, open, raw discussions. Thank you. So her efforts in organizing this, and Hannah right there by her side, can't thank them enough. Rachel, we want to thank you. You did a fantastic job, and this is certainly some great conversations moving forward. And I think Darren's point is well heard, and Zori as well. Like this is not the end of the discussion. This is a great jumping off point for some future work and future dialogue that needs to occur. So I know we will be in touch, and don't lose this momentum. Every time I go to something like this, I get all juiced up, and then 3 days later, I can't remember what I was excited about. So write some notes down about some people you want to reach out to and get that done. Otherwise, our momentum dissolves. Also want to thank Co-Chair Nazreen and the rest of the planning committee. You guys did a fantastic job. Really appreciate all the efforts. This has been a fantastic experience, and I hope you will join me in continuing the dialogue as we move forward. All right. Well, thank you all. Have a great rest of your day, and go out there and implement some change.